So there are a couple of different challenges how to use it. First of all, do we have access to the test, and is it paid for by the insurances? And around the world, there are all differences. Sometimes it's paid, sometimes it's not paid, sometimes the patients have to pay. So I think the biggest challenges is to integrate it to make sure this is covered as a test for our patients. Second, I think there are differences how liquid biopsies are done. Most of them right now are using targeted panels, which seem to expand every 6 to 12 months to bigger panels. But there are two particular completely different principles of liquid biopsy. One is the tissue-informed liquid biopsy, and the other one is the tissue-uninformed. So the first one, tissue-informed, is developed to increase sensitivity and specificity, particularly the sensitivity, because when we know the mutation present in the tumor, you can develop a higher sensitive test for the liquid biopsy for circulating tumor DNA. If you don't know the mutations, then you would do a broad spectrum. And when you do an NGS panel, you get mutations which have nothing to do with the tumor, but with normal hematopoiesis, which can be confusing. So the biggest challenge is still the sensitivity of the technology. Now, there are a lot of efforts to address this sensitivity by adding potential epigenetic testing to it, which has shown to increase sensitivity, such as DNA methylation, which may not depend on the presence of DNA mutations. There are also certain cancers where you don't have often a high frequency of mutation, such as gastric cancer. So here, the liquid biopsy implementation is much more difficult or useful in the treatment or diagnosis of recurrences. So I think the challenges is really the sensitivity and develop technologies which capture early recurrence, minimal residual disease, as well as mechanism of resistance. The specificity is extremely high. If it's positive, in fact, these tumors will recur if they're not treated. So there are a lot of different efforts right now in order to address the challenges as well as the strengths of this technology. The liquid biopsy are not at the point where we can act on it in the adjuvant setting to detect minimal residual disease. So there are many trials ongoing around the world to test what it means to have a positive liquid biopsy test after successful surgery. And the two basically clinical trial designs test if we can de-escalate treatment, meaning for the ones which are negative, not to consider chemotherapy as it would be standard, or to escalate treatment, to give treatment where patients usually should not get treatment or even get more aggressive treatment. Because we have seen with chemotherapy, we can convert 30 to 50% from a positive liquid biopsy to a negative, which will impact outcome. These trials are ongoing in the US, in Europe, and Australia. So we are all looking forward to the results and hopefully will show us and guide us how we can act in the future on the results of a liquid biopsy test.